This is an age of disruption, of profound revolutionary change.
What we're really asking ministers is to empower the ambassadors.
The only thing that you really push forth is the truth.
You don't see many women represented when it comes to the decisions as to how to handle the pandemic.
Good morning, everyone. My name is Sarah Tassier Ben-Sharif, and I'm a health reporter at Politico Europe. Thank you so much for joining us at Politico Live, the live extension of our unbiased journalism, for what's sure to be an exciting conversation. I'm here in the Residence Palace in Brussels, and I'm joined online by a fantastic panel of speakers to have a critical look at what's shaken health systems around Europe in the last few months. The many respiratory viruses that have reared their heads during the third year of the coronavirus pandemic. As if COVID wasn't enough, other respiratory viruses like influenza and RSV put an enormous strain on health systems already pushed beyond their limits. And that's true both for hospitals and for outpatient care, like in a GP's office. Just by way of example, in an average winter, it's estimated that there are over 213,000 hospitalizations just for RSV, just for children under the age of 5 in the EU, Norway, and the UK. And of course, those figures are before this season's surge in cases. This winter has been a confronting reality, one that further raises many questions about health systems' resilience and the tools that can help them better cope during seasonal infections. I hope that today we'll be able to look at the issue from many angles, from prevention strategies to diagnostic tests and to legislative tools that can help us better respond. But before we get into it, I've just got a few housekeeping matters to address. First, I'd like to thank our partner Stafford for making this event possible, and a big thank you to each of you online for joining us. I'd really like to make this event as interactive as possible, so please tweet your questions to @LivePolitico and also send your questions through to Slido using the hashtag RespiratoryInfectionsEU. Please do send your questions with your name and your organization, just so it's transparent for our viewers and our panelists. We're already keen to hear from you, so we've got a poll presented by Stafford, and the question we'd love to have you answer is, to relieve the pressure on hospitals and the health workforce during the winter respiratory viruses season, where do you think the focus should be? We'll have a look at the results at the end of the panel. Now, to get us started, we'll have some opening remarks from our partner, Daniel White, Stafford's Vice President of Sales for Western and Southern Europe. Daniel, over to you.
On behalf of Stafford Europe, we are excited to be here today to have a discussion about the future management of respiratory infections in the EU. This year's respiratory season saw a major surge of influenza, respiratory syncytial virus alongside COVID across Europe, and yet only 1 in 4 patients is being tested to detect the infection. Patients with respiratory co-infections are 4 times more susceptible to the need for mechanical ventilation, and their risk of death is twice as high as in patients with a single respiratory infection. Diagnostic tests should always be the first step in the patient's care journey. The COVID-19 pandemic and the co-circulating respiratory illnesses that have started to come back in force over the last year underscored the importance of access to quick and accurate diagnostic tests. Molecular polymerase chain reaction, PCR, diagnostic tests are the most sensitive and accurate medical technology for detecting respiratory disease at all stages of infection. Access to these tests must be maintained and further cemented into routine healthcare. As we now move towards an endemic situation in many member states, the question we must ask ourselves is how we can be better prepared as a healthcare community to prevent future pandemics. Users of rapid PCR across Europe have seen in real time during the pandemic that a rapid and accurate result has a direct impact on those patients most in need and can prevent spread and reduce the burden on the healthcare systems. We must ask ourselves how to leverage our COVID-19 investments to increase diagnostic capacity. Users of rapid PCR understand the need to test it also in a point-of-care setting, especially in high-risk settings like hospital admissions or emergency units. Multiplex PCR tests conducted at point-of-care deliver results for multiple pathogens simultaneously, simplifying the diagnostic process and leading to more informed treatment plans. Improved patient outcomes from these plans can lower hospital admissions and reduce health costs. Like many diagnostic companies, we rose to the challenge during the pandemic to provide rapid and reliable results to our clinicians and their patients. Not only did we bring to market a fit-for-purpose PCR test, but we ramped production worldwide to support the fight against the pandemic, and then innovated again to ensure our diagnostic test was able to maintain future coverage for any new variants. I've worked at Stafford for over 12 years, where our mission has always been to improve patient outcomes by enabling access to molecular diagnostic testing everywhere. Our commitment is to improve patient care by offering faster, more accurate answers with the PCR Plus advantage. We fully support the advocacy efforts for combined vaccination and testing strategies to protect healthcare professionals and the most vulnerable patients during the high co-circulation of respiratory infections. What we need now is an honest discussion about the importance of preventative measures and setting high quality standards for in vitro diagnostic tests and other medical countermeasures used across Europe. We look forward to the debate, and I thank you to Politico for organising this important event, as well as thank you to the speakers and all of you joining online. I look forward to seeing the outcome of the debate. Thank you.
Thank you, Daniel. And now let's meet our panelists. First, we have Dr. Andrea Ammon, Director of the European Centre for Disease Prevention and Control, the ECDC. We are also joined by Oliver Bisazza, the CEO of MedTech Europe. We have the pleasure of having member of the European Parliament, Sara Cerdas, from the Socialists and Democrats Group. She is a member of the Parliament's ENVI Committee and the Socialists and Democrats Group's coordinator for the Parliament's COVI Committee and Sant Subcommittee. Joining us as well is Professor Dr. Ray Wally, Vice President of the Standing Committee of European Doctors, the CPME, a GP and Associate Clinical Professor at University College Dublin. And last, but certainly not least, we have Professor Ab Osterhaus joining us as our fishbowl panelist. He is the chair of ESWI, the European Scientific Working Group on Influenza and other respiratory viruses, and he'll be challenging some of our speakers later on in the discussion. So, I'd love to get started by setting the scene, just by painting a picture of where we're at in this viral season and how we got there. It seems like many health systems were quite unprepared for the resurgence of things like RSV and influenza amid the COVID pandemic. So I'd like to start with you, Andrea. I wonder if you could briefly recap where we are now in the season, end of March, should be spring, but it's not, at least not in Brussels. And if you could help tease out what our blind spots might have been that landed us here. Not tease us, tease out.
Okay, thank you so much for the introduction. And it's certainly not spring here in Sweden with minus 11 degrees at night. The situation this winter was characterized by the co-circulation of several respiratory viruses. You mentioned them already. Influenza, we saw a early increase and in October, and it lasted approximately until Christmas, declined a bit, and then rose again with a wave of influenza B. So currently it's subsiding, but it's not over. Then the other one, RSV, also had an earlier onset and was more intense than we used to see. RSV is known to cause severe illness, especially in young children, but also in older people and individuals with underlying conditions. And then we have, of course, SARS-CoV that we got all familiar with in the past 3 years, and that circulated at lower levels than in the previous years. But since it came on top of the other two, it also had a severe, had also contributed to the severe impact on the healthcare services. So right now we see that COVID-19 is subsiding, RSV is subsiding. So it seems we're seeing the tail of this for this season.
Thank you. I do want to touch on the second part of the question, which is our blind spots. Like, how did we land here? You know, we've been in the midst of a respiratory pandemic for 2 years, and still we were surprised by respiratory viruses, you know, their resurgence. I don't know if you want to comment on that, Andrea, and thereafter, if anyone else wants to comment on that. I want to, you know, figure out like why were we surprised?
I don't think we were surprised. It was very clear that after 2 years with reduced exposure, very much reduced exposure to these viruses, that there is an increased susceptibility in the population. So we were actually expecting that there were more infections this winter, because this winter, the measures that were installed for COVID-19 to distance people were basically abandoned by most of the countries. So it was very clear that for instance, just the mere number of children that experienced their first infection this winter has increased by 2 cohorts instead of just having 1, which explains the considerable stress that, in particular, also pediatric hospitals were under. So it wasn't a surprise.
Okay. Anyone else have anything they'd like to add on that point? Well, I want to go over to you, Ray. I mean, you're a GP. Were you and your colleagues prepared for this surge in cases in of flu, RSV combined with coronavirus?
We certainly had an inkling it was going to happen. The briefings we got from our health service was that it could happen. We're lucky in Ireland that we have high vaccine rates in COVID vaccine. We're lucky that we have high influenza vaccine rates. We very much focus on that. We're at over 75% this year, with over 65%. The figure is still coming through. What wasn't expected was the amount of infection that affected children, possibly predictable, because obviously we had 2 years where people weren't congregating to the same way. Sort of difficult to prepare for this. All the problems in health services before the pandemic are still there. On top of that, you have an exhausted healthcare workforce throughout Europe, including Ireland.
Yeah, absolutely. Absolutely. One of the obvious questions that follows is, of course, around prevention and what can be done to boost vaccinations against respiratory illnesses to prevent people from getting really sick enough that they want to see their doctor or go to the hospital or emergency department. We have vaccines against COVID, of course. We have vaccines against the flu, and there are vaccines against RSV that are in the pipeline. Ray, just following up with you, what were patients telling you about why they were or weren't getting vaccinated, and how can we improve the prevention of these illnesses, at the bedside?
In Ireland, we have a very strong general practice continuity of care system. Mm-hmm. And we had in the order of, in the 90s of percentage rates of vaccine for our elderly with COVID. And that has stayed good in regard to influenza in adults. Where we certainly haven't done well is in regard to influenza vaccine for children. It was during COVID that was launched, available free at the point of delivery between 2 and 17-year-olds, and it came in the format of a nasal, so you didn't have a needle turning people off. And I don't think we've really communicated that. Like during COVID, we had phenomenal medical communication. There was a group of general practitioners, including myself, who were available to a lot of the media, and we dealt with a lot of the negativity by evidence base. But if you look at the statistics in regard to influenza vaccine with children, some of the benefits are phenomenal. 93% reduction in hospital admissions in children is what the study showed from the NHS back in 2014, 2015. And for example, in England, we had a great increase in strep A infections with a number of deaths. And part of that was because their previously successful influenza vaccine system wasn't achieving the targets that it previously did. So what happened is people got influenza and they then got comorbid strep A infection. So I think we need to learn that lesson. A lot of it is about communication. It needs to be able communication with people, and it needs to be very much saturation communication, which is what worked with COVID, because prevention is definitely better than cure.
Absolutely, absolutely. One of the things that we know when we talk about managing the burden. Oh, I see Andrea has a point.
Yeah, just to this topic, because we have done a lot of work helping and supporting the countries to raise the vaccination coverage, as these vaccines have shown to save really thousands of people from severe illness or death. So what is really important is to understand what people's knowledge and expectation and concerns are. And that is not done with big campaigns. You have to go at the local level and engage with communities, find trusted people in these communities, and also then find ways how to support healthcare providers and healthcare professionals, because study after study after study has shown that if people trust anybody for good information, then it's the healthcare providers. So we have to help them to cope with all the questions that they get and feel confident to have these conversations. And aside of this, we have also put in place the European Vaccination Information Portal that has information from Medicines Agency and us and the Commission in all languages as a reference point for trustworthy information.
Yeah.
I can expand more on this if you want, but I leave it at that right now.
Thank you. You're absolutely right that, we can't talk about managing the burden of respiratory diseases without talking about the healthcare providers providing that advice, providing that counseling, providing those interventions. I see that, and we'll touch on that further in a moment, but I see that, Ab, you have your hand up as well.
Thank you. I think these were very nice comments. And indeed, I think later in the discussion, we should talk a little bit about vaccination hesitancy as well, because what we have seen is that the vaccination levels in most of the European countries for flu has gone down. I think the example that we got from Ireland and from the UK, in fact, that's a fantastic story there because of the vaccination levels that we have in children. And I think it's quite important for influenza to realize that children are a very important vector in spreading influenza virus. And as a matter of fact, as Dr. Amon said already, during the winter holiday, we saw a dip in the influenza coming, and that has to do most probably with the closing of the schools as well. And I think what we see happening in the UK, a rather broad acceptance of influenza vaccination in children, which has protected also the vulnerable people, including the older adults. I think it is a thing that we have to stress more in Europe, because in Europe, if I look at countries like the Netherlands, Germany, France, Belgium, vaccination levels in children are very, very low. So I think this is a major point for the future also to be considered. Thank you.
Yeah, absolutely. Ray, over to you, and then we'll shift gears to the health workforce and how we can better support them. I also want to remind everyone to send their questions on Slido because we have it open, and we'd love to hear from you, of course. I've got pages and pages of questions, but I'm sure you have burning ones as well. So over to you, Ray.
In that pilot study, when they launched the flu vaccine for children, they found a 60% reduction in adult influenza infection. Children acting as a vector. So we need to emphasize this. Like if we look at the countries that had the lowest excess mortality rates in Europe, a lot of it was down to general practice community care. And they're also, where there's continuity of care, and they're also the countries that had the highest vaccine rate. So we need to bolster community general practice care, and we need to continue to educate people about the benefits of vaccination.
Yeah, absolutely. And maybe, Cerdas, I want to hear from you because, when I read the news from individual member states, I see that the health workforce crisis is an issue in a number of them, perhaps even all of them. And I'm just wondering, among your fellow lawmakers, is this a topic that's gaining traction? Are people talking about finding, European solutions or collaborating on best practices on how to bolster that health workforce that we've been talking about, the one that's delivering that care?
Yeah, exactly. That's a very interesting question because it goes into what can the European Union do in terms of health and public health. And as we all know, according to the treaties, provision of healthcare is a competence of each member state. So that includes the health workforce. However, protection of public health is something that is a shared competence. And that's how we managed to build during the pandemic the European Health Union through the approval of the different packages. Without a doubt, this is something that we are very much aware at the European Parliament. However, there's not much we can do in regards to our competences, but there's a lot that we can do when it comes to legislate better into providing better conditions for all member states to reach their goals when it comes to better health outcomes for the population, specifically through this triad epidemic that we saw this winter season. We already spoke here why the reason of why this is happening. What I can say is that at Parliament and at co-legislation level, we're preparing tools that hopefully will make it easier to detect, will make it easier to manage the preparedness part, such as the European Health Data Space. That's one piece of legislation that we're currently working on. So there's a lot being done here in regards to the functions and what we can do in regards to the treaties, but we're always very creative and we're very much aware that there's a burden in the healthcare workforce. And this burden comes even before the COVID pandemic, but without a doubt, it was stretched by the COVID pandemic. This was also a topic of my PhD studies before coming here to the European Parliament. Is something that I'm very much aware, and we need to take care of those that care for us. And that's something that together at EU level, but most specifically at member states level, should be done.
Yeah, absolutely. And sticking with you, and maybe Cerdas, when you talk to your citizens that you represent in Portugal, what are they telling you are their barriers to accessing care in these seasons where the health systems are overwhelmed? Is it that they simply don't have a provider, or that their provider is overwhelmed, that they don't have access to vaccination, don't have access to information? Like, what are they saying?
I come from a privileged member state where we have a national health system that covers all population, and it's mainly free. So anyone that is in need can access the health system. Of course, there's a burden, but here what needs to be done is how to better make the system more efficient. And in this regard, there's a point here that needs to be explored, which is health literacy. We have a problem in Portugal that a person has a back problem, a back pain for 3 weeks, and then instead of going to their GP or primary healthcare services, they go to the ER, to the hospital, and that floods the system. So there needs to be better health literacy on how to use the different systems, the different services of the system, of the health system that there is. And this is something that can be done through better health literacy. We also have a lot of, not only programs, but through the recovery fund that can be addressed for healthcare in regards to better digitalization and reduce a bit techno-stress among health workers and reduce the burden of work. But when I go back home, main complaints are that the system should be more efficient. And I truly believe that Portuguese authorities and the Ministry of Health is doing an outstanding work making that happen.
Thank you. I wanted to shift over to you, Oliver, now, because we're talking about the health workforce, but, making a diagnosis of RSV versus flu versus COVID isn't necessarily easy on a clinical examination. They share a number of symptoms. And one of the things that struck me about the COVID pandemic was the use of self-tests and, how those were deployed in our collective pandemic management to help people at least know if it was COVID or not COVID. And I'm just wondering if you can walk us through, what's available for healthcare workers and patients alike in terms of their own ability to diagnose these respiratory illnesses. But I want to hear what's available and also what's in the pipeline.
Oh, so Europe's tremendously fortunate that a wide variety of testing technologies are available. And I think early, systematic, good quality testing plays a critical role if we're to have a holistic public health response to respiratory infections, alongside the obvious, which include good hygiene, vaccination, etc. I mean, the testing can intervene in a great variety of ways. Obviously, when a patient is actually symptomatic and is presenting signs of respiratory illness, the testing is critical to do the diagnosis and to specify which respiratory infection she has, because whether it's COVID-19, RSV, or influenza or something else, that plays a critical role in getting her into the correct treatment pathway. And that's where some technologies in vitro diagnostics like multiplex assays play a critical role, not just to test for one respiratory illness, but to actually distinguish between them in a single test setting. You're right also that there can be a role for self-tests in some cases, and on the professional side, point of care testing. So we're not only doing this in a professional lab environment. There is a big role for professional laboratory diagnostics, but they need to test a huge number of things each and every day, not just respiratory infections. So as to not overly burden those professional labs, that is where the role of other diagnostics come in as well. And the other thing to bear in mind, of course, is while the classic testing scenario is for when a patient has the actual symptoms of respiratory illnesses, there can also be a role to play in testing certain pre-symptomatic or asymptomatic individuals, where that makes sense, right? So if perhaps a particular population like our healthcare workforce, who we need to keep as healthy as possible and protect from sickness, that could be one example of a population that we test, even if they're not preventing symptoms. And the testing can also be used to confirm if an individual has the sufficient antibodies against a given respiratory illness, if it's flaring up right now. So that can be used in a general sense, and it can also be used to confirm that post-infection or post-vaccination, those antibodies have actually been developed to the desired effect. So there are a range of diagnostic testing solutions available. I guess the point for me is we need to be very holistic in our response to respiratory infections like this, because we just passed an exceptional winter. We passed, we hope, the COVID-19 pandemic. But beyond those exceptional times, we must remember that even in a given year, a typical year, a non-exceptional year, respiratory illnesses are actually having a huge impact on Europe's healthcare and economic systems. And I think some of the statistics you mentioned earlier are testament to that. So there's only so much we can do to actually prevent these infections from happening outright. We should use those preventive measures as much as possible, but we need to accept that despite those good efforts, an unfortunate number of infections can and will occur. So testing and other public health measures to manage that are critical, and to manage the situation in a holistic manner.
Absolutely, yeah. We have a question from the audience. This is a question from Isatu Sar. It's the most upvoted question, so I'll start with that one. So diagnostic tools must be accurate and need to be properly assessed and monitored. Are there plans to incorporate the IVDR, I think it's a regulation 2017-746 in hospitals? I don't know if anyone wants to take that.
I can take that if you like. That regulation is the reference European regulation for the safety and performance of these diagnostic tests. They apply absolutely to the commercial manufacturers who place these tests on the market in Europe, and is being transitioned in as we speak in the next couple of years. Now, part of that regulation can also apply to tests like diagnostics that laboratories or hospitals might develop in-house. And so, yes, there is a certain amount of testing that can happen in-house, especially if when we're in the early stages of studying a new disease or developing diagnostic tools for that while the commercial market is upscaling. So yes, those are in the scope of that regulation. And I understand the laboratory medicine community is spending a lot of time navigating the complexities of that regulation so they can make those in-house tests available.
Great, thank you. I want to pivot over to you, Ray, and ask you how. Oh, sorry, Andrea, you have a comment. We'll go ahead with that first.
Yeah, no, thank you. I just wanted to say, I mean, for us, it's very crucial also to see this holistic, that we have a possibility, and that's what we're saying, that people should be tested when they're tested for respiratory symptoms for all three of these viruses. But what is then also important is that there is a mechanism to channel sufficient number of samples to reference laboratories for genetic testing, because this is very important, as we saw for the COVID variants. It's important to look for influenza strains that are circulating, whether they match the vaccine composition. So this next step is equally important to pay attention to. And the early diagnostic is not only important from public health view, that we know when activity is rising, but it's also important from an individual point of view, because there are antivirals for those individuals that have a high risk for complications, but they work best when they're applied like within the first 48 hours after symptoms. So also here, a diagnosis is important because they are virus specific.
Absolutely. Ab, you have your hand up.
Yeah, I wanted to make the same point as Dr. Armand was making. I think it is important that all this point of care testing that we are talking about in the hospitals is of extreme importance, and feeding it back into national databases, but also to ECDC, that's absolutely crucial. And I think, on the other hand, it's also quite important for the local GPs to realize that they usually do not have access to the PCR testing, that this self-testing in combination with the data that are being provided by ECDC and also by national databases, that they keep a close eye on that. And as was said before, it's quite important that we realize that definitely for influenza, but also for COVID, there is good medication today. For RSV, it's only symptomatic treatment at the moment, but it's very important if you have high-risk patients that indeed when they come with a respiratory infection and it is flu or it is COVID, that these people can benefit tremendously from an early diagnosis. And even if let's say the self-testing or the GP office testing is not as accurate as, or not, it doesn't reach the same standards as the PCR, I still think it has a place to play, especially in view of the information that's being provided by national authorities and also ECDC.
Thank you. That segs really nicely into my question to Ray, which is that, I'm trying to imagine for you you're running your clinic and patients are coming in with their own diagnostic results. Would that help you or hinder you? Like, I'm trying to understand, of all the gamut of tests that are available, what would be most helpful to you, or what's not even existing that you would love to see developed?
Well, certainly a national licensing of these, or European licensing of these, so we know the degree of specificity and sensitivity of these tests. In Ireland, we do have what are called sentinel practices in general practice, and we act as an early warning system. And I know there is a study going on in University College Dublin, the Prudence study funded by EU, in regard to the use of point of care testing. I know in certain jurisdictions, my colleagues, the Swedes, the Dutch, they already use CRP testing. I'm afraid certainly we need to improve on all of that. I would go back to a point that the MEP Ms. Serda says. We do have a difficulty with health literacy in all European countries. We have a scarce resource called a doctor or healthcare worker, and it's not uncommon for somebody to book into an out-of-hours clinic with 2 hours of a cough. Once upon a time, you'd ask your grandmother what to do, or you'd ask your mother what to do, and we need to ensure that we preserve the scarce resource of health access, especially for our elders, who often are the ones who are displaced by this. And certainly point-of-care testing, if effective, if highly specific and sensitive, and by way of an EC license, would be supportive for us to make quicker decisions and more accurate decisions.
Thank you for that. I'm going to take another question from the audience. This one is from M. Martins, and thematically we're going a little bit back to vaccines, but M. Martins asks, what about spreading the use of differentiated and tailor-made vaccines for the elderly in order to effectively protect them better? Don't know if anyone has any. Dr. Ammon? No? Ab?
Yeah, well, of course, for influenza, we have vaccines that are specifically meant for elderly people, and those are, at least for influenza, and those are vaccines with either a high dose or with an adjuvant. The benefit of that, I think the most important thing is that people get vaccinated. The differences between these vaccines, well, the high dose vaccine for flu gives a slightly better outcome. For the adjuvanted vaccines, it's even less. So I think it may be important to use those vaccines. On the other hand, I think it's crucial that people at risk, and that includes older adults, that they are vaccinated. That's the most important point, as it's being stressed by WHO as well. So these specific vaccines for specific populations, yeah, I think we should spend more time on that, because I think at the moment, especially when, and most experience is with influenza vaccines, obviously, the benefits of those specific vaccines, well, they are there, but they are limited, I should say. And that doesn't mean we shouldn't use them, but we need to do a lot of work in that direction to get vaccines that do much better in elderly people, older adults, but also with people in people with specific risk. What we haven't stressed here yet is the importance also of healthcare workers to be vaccinated. I think as a means of example to the public at large on the one hand, but also to protect their patients, yeah, their fragile patients, it's important that they are also in the first line of being vaccinated.
Yeah, absolutely. This question is probably for you, Oliver. When mentioning, it's from Anonymous, I think I'm going to try to wrap my mind around it, but I think it's asking that when mentioning early diagnostics, are there plans to further integrate them into a long-term surveillance system, and how? I don't know if you've been in conversations with perhaps the ECDC or other agencies about that.
Not specifically, but obviously, you know, the value of the diagnostic information that's coming out of these tests is manifold. I mean, there's obviously a clear direct benefit for the individual patient under examination to get him or her into the right treatment, etc. We've talked a little while ago about how critical that is. But also, if properly harnessed, the information coming out of diagnostics at the population level is also potentially enormous. If this can be systematically collected and connected into things like digital monitoring systems, then yes, you have the potential to significantly bolster surveillance systems. You also have potentially the opportunity to further the study of the disease itself. And European initiatives under negotiation, like right now, like the European Health Data Space, do offer the potential promise of enabling that if we can somehow gather and liberate and process all that diagnostic information in an anonymous and controlled fashion, and get the benefits of that diagnostic information sufficiently spread throughout the medical community, whether that's the hospitals, the public health community, or the industries which are researching the next generation of diagnostics and medical technology tools. That's what I would say. But perhaps Dr. Ammon has also a perspective on that from a surveillance point of view.
Yeah. Thank you. Yes, I'll hand it over to Dr. Ammon.
Yeah, thank you. I mean, for our recommendations in the surveillance, we don't give recommendations for specific tests. We say at the maximum what kind of specificity and sensitivity a test should have in order to be valid for surveillance. But that's the maximum that we do. Now, what we have seen during the pandemic is that when there is new tests coming to the market, there is at the European level no entity currently that does a validation of these tests, for instance, for surveillance for all the EU countries. And that is one of the ideas behind that in our new regulation, the creation of European reference laboratories was actually agreed. There have been discussions to install some of these networks and reference laboratories for human health. But now the pandemic made it very clear we need those. And validation at the EU level of such tests would be one of their tasks. And we are now together with DG Santé putting these networks in place.
Yeah, thank you so much. It sounds like we're talking. Oh, yeah, Oliver.
Yeah, if I could just quickly echo that, I mean, these reference laboratories that Dr. Amon mentioned are indeed a key feature of that EU regulation on in vitro diagnostics that a previous audience member asked about. They don't exist yet, but they are, as we speak, in the process of being created. So we really rely on high quality labs across the member states to come forward and apply to be reference laboratories. Now, they will do that validation that was just mentioned primarily for the highest risk tests. These are tests usually for managing population level threats like COVID-19, for instance, where there are, in fact, for the first time, European level acceptance criteria on sensitivity, specificity, etc., that are supposed to be harmonized across the Union and validated by these laboratories. Now, it's critical to understand that level of EU-wide specification doesn't exist for all types of tests, because some diseases, including some respiratory diseases, are less serious, if I can use that word, when compared to COVID-19, for instance. But at least for the professional laboratory diagnostics, there is always, or there should always be, a validation of the test's performance on the side of the laboratory user, because these tests are under European regulations brought to market with specific claims from the manufacturer about how sensitive and specific they are. The claimed amount is on there, and it's one of the first things that a professional laboratory will tend to validate when receiving those tests before then going on to use it in a clinical setting. So again, that is happening at the level of individual labs. If we want the benefits of that validation work and the information gathered to be leveraged at the European level, it again requires that more systematic collection and sharing of data, which perhaps initiatives like the European Health Data Space can make possible going forward.
Thank you very much, Oliver. I'd like to hand it over to Ab for the fishbowl comments now. So Ab, I'll hand it over to you if you'd like to challenge any of our speakers.
Well, we had a lot of agreement there. That's a pity. But basically, I think when we see what we have been talking about is how are we going to deal with future seasonal respiratory infections. And as we have stressed here, there's basically three infections that we have been discussing: acute respiratory virus infection. First of all, it's influenza. Then we have A and B. Secondly, we have RSV. And thirdly, we have COVID. Well, a lot of attention has been paid to COVID in the recent years, obviously. And I think, and a very important point there was that the whole diagnostics, in fact, has gone through an avalanche of new techniques, new technologies. And that was one of the positive points, or perhaps the only positive point of the last pandemic, that we are fortunately creeping out from at the moment. And I think all the diagnostic testing, as we have discussed, point of care testing especially, triple point of care testing is quite important. So that's the whole testing business. I think, as was just said by Oliver as well, it's not only those three infections, obviously. We still have human metapneumovirus, we still have rhinoviruses, so there's a lot of other virus infections there as well that we have to be prepared for. So the triple diagnostics as such is quite helpful, it's quite good, but we have to keep in mind that there are other important infections as well. So that's the whole diagnostic scene. And I was very pleased to hear from Dr. Amon that indeed this European ECD initiative is ongoing. I know, for instance, from the Netherlands, when diagnostic tests were used, there was a network actually of laboratories that were testing both sensitivity, specificity. So before you would buy a test, you could look into that, and that was freely accessible. So that was a very good thing. So I think that whole issue of diagnostic testing, both at the level of the GP, but also at the hospital level, is absolutely important. Well, the other cornerstone that we have been discussing is, of course, vaccination. So we have good vaccines against flu. Of course, new flu vaccines also on with the data they've generated on the messenger RNA vaccines and the other possibilities there. New vaccines are being developed, and I think the big challenge in the future for flu and COVID, and I think we can add RSV now as well, as we heard, because there are at least 2 vaccines coming to the market next year. The big question, of course, is how are these vaccines going to be used in the future? Because we know that these viruses come back every year, but we don't know what, for instance, is the longevity of protection of these vaccines. How fast the viruses are changing. We know that for flu for a long period. For COVID, we are in the middle of it actually with all the new Omicron variants. For RSV, I think it's less serious there because the change we have RSV A and B, and still if we have a vaccine, it will probably protect against both. Yeah. But how are we going to integrate this whole issue of vaccination? So it's as was said before, it's not only the children, but it's definitely also older adults. The vaccines that are forthcoming will be for them as well. So I think it's quite important to understand in the future how we are going to manage this new vaccination era for acute respiratory infections in the wintertime. And I think there are already tests ongoing with double vaccines for influenza and COVID, and how RSV fits into that is the big issue. Well, absolutely. Then the last point that we discussed, and we should address briefly, is what can we do especially for the high risk individuals, the high risk patients? What can we do after early diagnosis? Because I want to stress again, this early diagnosis for those individuals is crucial, especially since we have good antivirals against influenza, we have good antivirals against COVID, and we have also for the longer term, we have other medications. So this whole issue of the use of antivirals, of which I can say, if you look at Europe, it's something that's completely underused. If you look at the US or Japan, and we look, for instance, at the use of medication against influenza, in Europe, it's actually barely done. And I think that's an important point to consider. When we have good medicines, especially for the risk groups, I think we should definitely make sure that with the good diagnostics, we can use them at a very early stage, because we know, especially for the antivirals, when we are going to use them later in the process of disease development, they are barely useful. So I think this whole combination of, on the one hand, diagnostics, that's what it all starts with, and that in the background, as I said before, the epidemiological surveillance that's going on in respective countries being coordinated also by ECDC. I think that's the cornerstone, the first cornerstone. Second cornerstone is, of course, is vaccination, how to prevent. We see vaccination levels going down, so we have to combat this whole issue of vaccination hesitancy, which has increased for whatsoever reason. And that's not to the virologist or the epidemiologist, it's other disciplines that should be involved. And the last point I made was indeed about antiviral treatment. Do it as early as possible and use the antivirals that we have today. So I think if you look at the whole picture there, so we have these 3 elements that have improved enormously over the past couple of years, and I think we should use them in a responsible way in the future and know exactly how they play together: diagnostics, vaccination, diagnostics, and antiviral usage.
Thank you very much, Ab, for your comments. Really appreciate them. I'm going to give one last word on this point to Oliver, and then we'll move on to legislative tools, because I do want to talk about the health data space, because it's juicy and it's sexy and it's important and has lots of potential. So Oliver, on to you.
Thank you, Sarah. So indeed, we're agreeing with each other a lot in this particular event, which is good, I guess. On the other hand, we have talked quite a lot about the role and responsibility of individuals the industry, of the public health services, etc. One thing we haven't talked about so much, I guess, though, is the unique role the European Union can play at this time, because respiratory infections tend almost always to fall into that famous category of cross-border threats, and stepping up the European Union level coordination, resilience, and response to cross-border threats was one of the key lessons that was meant to be learned from COVID-19. So alongside the actions that happen within the member states that we've talked about a lot today, there is also that critical topic of international cooperation within the European Union and beyond. So the European Health Union, which was created in response to COVID-19, is still in its early days, but really includes some exciting opportunities like the HERA, the Health Emergency Response Authority, which can play a role not only in anticipating and managing crises like COVID-19, but also facilitating cooperation. For instance, coordinated procurement mechanisms between the member states so that we can collectively purchase and make available the tools needed to manage these infections. That joint procurement is already happening for things like the vaccines, which is great, but it could also potentially be used for other kinds of tools for the healthcare profession, be it other medicines, be it medical devices, or be it some of those diagnostic tools we've talked about before. The vaccines is perhaps high in the popular imagination because of how there was joint purchasing of COVID vaccines, but HERA is here and HERA is in its operational stage. So activities like joint procurement are an opportunity to be used for the fullest, perhaps. And that's an example of something that the European Union can offer alongside the critical role of health professionals and individuals.
Thank you, Oliver. Yeah, you've answered one of the questions I was just about to ask from the Slido, which is that will HERA play a role in supporting member states to prepare for the next respiratory season? You've touched on the potential roles that HERA can have. I do want to go over to you, Sara Cerdas, to talk about the EHDS in a little bit more detail, just because it has so much potential. But I would love if you could walk us through exactly how it could help with the surveillance and the preparedness. Like, what exactly is the data that it could glean for public health officials to better prepare for the next respiratory season?
Yeah, so basically what happened with the European health data space is kind of like a roaming for your health data, meaning that when you go to a physician or a health professional in Portugal, but then you travel to Brussels, and you need to go to your doctor in Brussels, your health file will be translated for language that the Belgian doctor can easily understand, so an official EU language, and that will increase and improve provision of health. That's the use of primary data. However, there's another big part of the European health data space, which is all these data can be used for the secondary use of data. And it's in this secondary use of data that we are pretty much highlighting the importance that these data will have in terms of surveillance. In this regard, and it's important that public health agencies have duly access to the data, so they don't need to go through all the steps in order to have timely access to the data, because surveillance means not only monitoring but acting on the monitoring. So it will allow us to have better preparedness and better awareness, and that through the recent modeling models that we have, we can anticipate different peaks, we can anticipate different supplies and demands of medicines, of medical devices, medical substances, vaccines, and we can anticipate, for instance, the flu season, but also the respiratory diseases and other diseases. So it will be a groundbreaking regulation here at the EU. We're currently negotiating it at Parliament level. We know a Council is also negotiating it at their side, and then we're going to all sit on the table and try to come up with a common ground. There's a lot of question marks on how this will be done and the different support the different member states need to make it actually happen. But I'm very confident that we're going to make it happen and approve it by this, which is mature already, because it will change the way we deal with health data across the European Union. We're talking about 27 member states and almost 450 million citizens. And the portability of the health data will change not only our understanding of diseases, but it will greatly improve research because you're going to have access to more comprehensive cohorts. And here, just highlighting rare diseases is different if you study rare diseases in a network of 4 countries than if you study rare diseases in a cohort with 27 member states. So just to give an example, it's very juicy indeed, and I'm really glad to have the honor to be one of the negotiators of this. And yeah, I look forward there's a lot of work coming up in order to make it right, but I'm very helpful on that.
Thank you. Yeah, thank you so much. It's hard to imagine just how much data there could be if everyone's health data were available for surveillance purposes. Andrea, over to you. And then I've got a follow-up question
thank
for you
you.
as well.
I mean, it has been already said, for us, it's really kind of a dream project. It's a very courageous plan, and I'm not aware that anything like this exists anywhere else in the world. So it's really groundbreaking work that is done here. And if it succeeds, then I think we have really a profound source, additional source for our surveillance data. If we get timely access, that is, as Sarah Serra said, right now still under debate, and it's not only for the ECDC, but it's also for the EMA, that this is very important for us to be as useful as possible, that we have really timely access. And of course, it will depend on how much the citizen trust this platform to leave their data in, and that it's used in a GDPR compliant and transparent way.
Absolutely. Absolutely. Andrew, I've just got one last question for you before we wrap up with a little round of last comments. The ECDC proposed for RSV to be included in the list of notifiable diseases, and I was just wondering, when will that decision be finalized? And practically speaking, if it does become a notifiable disease, what would that change for health systems and their ability to prepare for seasonal infections?
So we have provided our comments that we have at the technical level already consulted with the colleagues in the member states to the Commission, because it's DG Santé that will go through the legislative process of establishing the list of diseases under surveillance. We took the opportunity to change propose a few other changes, not adding, but different kinds of surveillance for other diseases. And then it goes through the comitology process, and that is not under our control. Now, what it will change is that currently some member states have, for instance, RSV in their regular surveillance, others don't. So it would hopefully streamline a bit more the data that we get on RSV. And as Ab Osterhaus mentioned, there are vaccines coming. So it's very important before these vaccines are launched to have a baseline of the disease in the population to see how we can shape then also the vaccine recommendations for these new vaccines, to address it to those parts of the population that are most benefiting from it. In overall terms, if it would support our and WHO's joint guidance from last year to have actually an integrated surveillance for those 3 viral infections, which we will support the member states to put in place. And so from the next season onwards, our reporting will be on all those 3 virus infections together.
Thank you very much. We'll just do one last round of any last burning questions. If so, raise your hand. Or any last burning comments. Ray?
Like a lot of our talk has been on viruses. At the end of the day, we equally still need access to antibiotics, and this winter has resulted in a shortage of narrow spectrum antibiotics in Europe, and there are 35,000 people die in Europe due to antimicrobial resistance, 1.3 million worldwide. So we need to ensure that we have good vaccinations, good point of care testing, but when we do need antibiotics, we need antibiotic access. And the success of the vaccine delivery system for COVID in Europe means that that should be replicated in regard to narrow spectrum antibiotics and broad spectrum antibiotics where required.
Thank you. Thank you. Very short last comment from Ab, and then I'll wrap up.
Yeah, it's a very short comment. So first, I would like to say that I appreciate this discussion between the scientists on the one hand and the policymakers on the other hand. I would like to point out that at our big influenza meeting in Valencia this year from ESRI, we have a specific science policy interface where the scientists talk to the politicians and the policymakers. And I think that is an ideal place to continue this kind of discussion. Thank you.
Thank you all so much for your time, your expertise, and your engagement, and thank you as well online. This brings our fantastic exchange to an end. Thank you so much for our speakers, for participating and joining us today. We've just heard from them how much the burden of respiratory viruses weighs on healthcare systems in Europe, and importantly, the many tools we've actually got at our disposal to help mitigate that in the future. Now, let's just have a look at the results of the poll to see what you guys thought were the priorities. So we'll switch over to the poll and see. So to relieve the pressure on hospitals and the health workforce during the winter respiratory virus season, where do you think the focus should be? And more than half of you thought it should be on improving the infection prevention and control programs. 17% of you thought it should be in implementing automated testing strategies to support the workforce. A same percentage thought it should be on integrating vaccination campaigns with point-of-care testing, and 9% thought it should be in implementing accurate multiplex testing in pediatric departments. So it sounds like good old IPAC is the way to go for the vast majority of you. Thank you very much. So I want to thank each of you in the audience for your engagement and your interest, and I also want to thank our partner, Stafford, for making this event possible. As always, we'd love to hear from you about what you thought of the event, so please send us your feedback at live@politico.eu. And a note to mark your calendars, we have a great lineup of events for the year ahead that you can find at politico.eu/events, including our Healthcare Summit on October 24th and 25th. We hope to see you there. And just to summarize the main takeaways for today, I really think that we focused on talking about the need for healthcare worker trust, the need to bolster community healthcare and health literacy. We also talked about the importance of early diagnostic tests because they matter for therapies and for outcomes for patients. And lastly, we talked about the need for timely data and surveillance and how that can play a key role in anticipating peaks and the demands for therapeutics and for supplies. Thank you all again so much for joining us, and we look forward to seeing you at our Healthcare Summit and at all of our events until then. Goodbye.
This is an age of disruption, of profound revolutionary change.
What we're really asking ministers is to empower the ambassadors.
The only thing that you really push forth is the truth.
You don't see many women represented when it comes to the decisions as to how to handle the pandemic.